Good evening. My name is Ganguli. I'm a Hamilton Gastroenterologist. This evening, I'll be presenting with Priscilla Matthews, who's a medical student on two common GI conditions. One of them is heartburn or reflux disease, and the other is colon cancer. Priscilla and I are going to tag team. She's going to talk about the medical aspects of heartburn first. I'll get into the lifestyle aspects of it. Then we'll have a pause for questions and answers. And then after that, we'll talk about colon cancer, which unfortunately affects about 6% of the population. And once again, we'll see how strong a role lifestyle medicine and lifestyle can play in preventing that. We're actually a very small group, I think. Well, how do you want to do questions, Daniel? Should we just do it at the end of each part, maybe at the end of the heartburn and the end of the colon cancer? Okay, why don't we do it like that? So I guess without any more ado, hopefully everyone can see the screen that says gastroesophageal reflux disease, and I'll let Priscilla take it away.
Okay, so hi everyone, I'm Priscilla, as Dr. Ganguli introduced me. So I will be starting the presentation on GERD and then colorectal cancer as well. So I just wanted to start by talking a little bit about the anatomy of our GI tract. And so we have our mouths, which is where we take in the food, and then we have the esophagus, which is this long pipe that kind of goes down, connecting our mouths to our stomach. And then our stomach kind of sits under the diaphragm. You can kind of see that connection here. So that's just the basics of the anatomy. Now, one of the really important functions of the stomach and stomach cells, sorry if you can hear my dog barking, he's outside, but one of the very important functions of the stomach cells is to secrete acid or gastric juice. And this gastric juice is very acidic, and it really helps to break down bacteria. It helps start the digestion process. And so it has a really important function, but acid can also be very destructive to our own cells and our own tissue linings. And so we need protection from it as well. And so we have these gastric mucus cells shown on the bottom here that can help secrete mucus, which is rich in bicarbonate. And when bicarbonate interacts with acid, it kind of helps to neutralize the effects of the acid. So they kind of balance each other out in that way. So this is kind of the acid function of the stomach. Okay. Now, what is GERD? GERD, or gastroesophageal reflux disease, is a condition in which we have the acid from the stomach cells that it's being secreted kind of going backwards or refluxing back into the esophagus. So on the left in this picture here, you can see that the blue acid is contained within the stomach, and we have this sphincter. The way I like to describe the sphincter is kind of this muscular portion of the esophagus that kind of pinches together to form a seal. And normally it is closed when food is not being passed down from the esophagus into the stomach. And that kind of helps the acid not travel backwards and stay in the stomach. But in GERD, we have sometimes we have issues in the sphincter function, and it doesn't pinch together as tight as it should. And we see that acid is kind of flowing backwards. So this is a very common condition, and we'll talk more about it. So why does this happen? There's many different reasons. Motor abnormalities. So sometimes the esophagus, which has muscle tissue and helps to propel things downwards, that doesn't always work properly. And so if there's an issue with movement and the muscular portion of the esophagus, that can kind of allow some of the acid to travel back. The sphincter tone. So like I said, if that sphincter or those muscles that open up to let food down from the esophagus into the stomach, if they're open too much or if they're not closing properly, it doesn't form that appropriate seal, and we have some acid traveling backwards. Sometimes there's delayed emptying of the stomach, and so the acid is sitting there for longer than it should. increased pressure in the abdomen. So that can sometimes create pressure on the stomach and trigger the acid to move backwards as well. And then sometimes some medications, so NSAIDs or things like ibuprofen or Advil are drugs that can kind of worsen GERD. So next I'll talk a little bit about the pathophysiology. So I've already kind of touched on this, but the esophageal sphincter is really, really important in preventing GERD or that acid reflux from traveling backwards. And so if it's not strong enough, if it's not functioning appropriately, we see, or if it's relaxed a little too much, we see that acid traveling backwards. So that's kind of demonstrated in this diagram here. You see that the blue acid kind of going backwards when the sphincter is not completely closed. Hernias are also something that can contribute to GERD symptoms. So a hernia, I like to think of it as something popping out inappropriately. So here, what you see on the left is a normal anatomy. So the esophagus kind of travels through our diaphragm, which is a muscle that sits right below our lungs, and the esophagus travels through the diaphragm through a hole in order to connect to the stomach, which, as I mentioned earlier, sits below the diaphragm. But sometimes some of that stomach, which normally sits below the diaphragm, kind of pops up, and you can see that on the right-sided photo. Because the diaphragm is a muscle, it kind of pinches lower down the stomach, and that can also worsen acid reflux. So hiatal hernias are a risk or can contribute to GERD symptoms as well. And then finally, we have impaired esophageal mucosal defense system. So our esophagus actually has some tricks that it will use in order to prevent the effects of acid coming back and hurting the esophagus. So for example, it will secrete the saliva that we create in our mouths kind of contains bicarbonate. So you can see that at the top of this photo here, and that also travels down with the food to kind of protect the esophagus from the effects of the acid. So remember, as I mentioned earlier, that the bicarbonate that is secreted in mucus can help to kind of neutralize the effects of the acid. And then there's also submucosal glands, or these cells in the esophagus that secrete bicarbonate as well. So all of those really help to protect the esophagus from the acid. But if they're not working properly, if the esophagus's barriers are not working properly, then we can see worsening of GERD or GERD happening.
I'll just remind everybody, GERD just means acid or sour taste. But I want you just to define a little bit more what GERD is, because that some people might not understand that. Can you tell us a little bit more about that?
Yeah, so GERD, sorry if I didn't explain this properly earlier. GERD is it's defined as gastroesophageal reflux disease, and it's basically when that acid that is secreted into our stomachs refluxes or travels backward into the esophagus and can cause those symptoms here, such as heartburn, which is that burning discomfort feeling that we feel in our chest sometimes. These symptoms do tend to happen after meals or when you're laying down and that's because when you're sitting up, gravity kind of works to pull the acid fluid down, but then when you're lying down, it can kind of flow backwards, if that makes sense. People may also have symptoms of regurgitation or nausea, feeling like throwing up, difficulty with swallowing, which is something we call dysphagia, pain kind of in that chest or upper belly region, and then belching or kind of belching. I just did want to mention here that chest pain can be a sign of GERD or a symptom of GERD. However, if chest pain can also indicate many other serious issues, and so if someone is experiencing chest pain, it's important to get that checked out and not just assume that it is GERD. We don't want to automatically assume, because it could be something more serious.
That's a good point, Priscilla, because sometimes we get confused with, like I'm a heart doctor. So I think heart pain and Dr. Ganguli and yourself are gastroenterologists and reflux. So I think some of the clues that sometimes the body has trouble understanding what is what sometimes. So we can get this confused. So what I think about is heart pain is usually a heaviness or a tightness that comes on with activity. You mentioned GERD or like heartburn that will come on after food or lying down. So it's just some of the tricks we look at, but sometimes we get confused about that. So to sort that out. So thank you for sharing that. I'm sure we all made the mistake of making the wrong diagnosis sometimes. So I think we have to be very careful about that. So thank you for sharing that.
Yeah, definitely important to differentiate cardiac versus or heart versus GI or gut type of problems. Okay, so how do we kind of investigate these symptoms, or what do we do when our patients tell us that they have reflux? So GERD is actually a clinical diagnosis. So when patients describe some of these symptoms of reflux or nausea, we can make a diagnosis based on that. And then one of the other things that we do is we start patients on a PPI, or a proton pump inhibitor. So that's a medication, and some of you may have heard of medications such as pantoprazole or omeprazole, which are examples of PPIs. And we give that to patients for a couple of weeks and see if they feel better with it, and if that kind of improves the reflux symptoms. And if it does, that points towards a potential diagnosis of GERD. So that's called the PPI trial. That helps us kind of distinguish if it may be GERD. And then sometimes we do a scope or an EGD, an upper scope that goes to the mouth and down into the esophagus. It has a little camera attached to it to take a look at what's going on inside. So if a patient is presenting in a way that's abnormal or unusual, and they're not responding to the medications, the PPIs, sometimes we may actually go in with the camera and take a look to see what is going on, because other things like cancer or other diseases could be causing it as well. So we'd want to get an idea of that. Okay, so before we talk about lifestyle modifications, some of the medical treatments that we use, or the medicines that we use, I already mentioned this, is the PPIs. So just to give a little more detail, our proton pump inhibitors, what they do is they block proton pumps that are on our stomach cells. So going back to what I mentioned in the beginning, we have these pumps on our stomach cells that pump out protons or acid molecules. And so when we use PPIs, they kind of block those pumps a little bit and prevent them from pumping out so much acid. And that way the stomach lining is not, or the stomach environment is not as acidic, and it doesn't damage our esophagus as much if it does reflux. So that's one thing that is done. And usually the PPIs are taken once or twice a day before a meal to help those symptoms. And then surgery is sometimes required as well. This is required for people that the PPIs are not working for, or they're not able to tolerate them, maybe due to side effects or other difficulties. So it's something called fundoplication. And to put this in simple terms, it's when we take a part of the stomach that's at the top, or we call it the fundus, and it's kind of wrapped around the esophagus, as you can see in this photo here, and then kind of stapled together with the other side of the stomach. So essentially what this helps to do is kind of help reinforce the sphincter, that the lower esophageal sphincter that normally helps to, that normally connects the esophagus to the stomach, and kind of make that more secure. Because as I mentioned, the sphincter activity can be loose in some cases when that acid reflux is back. So this kind of helps to reinforce the anatomy so that acid is less likely to reflux backwards from the stomach into the esophagus. And I just want to touch on a few complications. So these are some big words here, but these are some things that we see with chronic or long-term acid reflux. So these are some complications that can occur. We have something called erosive esophagitis. So this is essentially a lot of irritation and inflammation that happens in the esophagus because that acid is flowing backwards. So sometimes we can see erosions or ulcers, which is basically when that acid starts eating away at the esophageal cells and esophageal wall and destroying it. So that can happen. We also sometimes see strictures in the esophagus. Again, this is a chronic effect, so something that happens over long-term acid reflux. And what that can cause is a lot of scarring. So with that repeated inflammation and irritation of the esophageal walls, we see strictures that result. And that can kind of limit the function of the esophagus and prevent it from working at its best. So that's not a good complication. And then sometimes we see something called Barrett's esophagus as well. So with that acid exposure that happens a lot, sometimes this can interfere with the cells and their DNA and their makeup, and that can lead to cell changes that can make those cells more likely to turn into cancer. So Barrett's esophagus is not cancer itself, but it can lead to the development of cancer later on. And those are obviously things that we do not want. Okay, now I'll hand it over to Dr. Ganguli.
That's awesome. Thank you very much, Priscilla. That was beautifully done. So hopefully, can you everyone see a screen that says GERD and lifestyle? Okay, great. That's a good start. All right. Priscilla's given hopefully a good explanation of what heartburn is and what the conventional treatments are. But it turns out that in many ways, I now see it. I'm a gastroenterologist, but I'm also qualified in something called lifestyle medicine. I now see that heartburn is basically one of the ways that our body is perhaps trying to tell us that it's not completely happy with our lifestyle and what we're doing, because there's the things that tend to cause heartburn tend to make us unhealthy in other ways too. This is basically the list of lifestyle modifications that we generally go over with patients in terms of treating their heartburn, because often patients have a reluctance to go on medications and they prefer to treat the cause. As Priscilla nicely explained, this muscle, the sphincter between the stomach and the esophagus, it opens up to let food go down, and it's supposed to stay closed to stop the acid coming up. But there are a bunch of things that relax that sphincter. They basically open it up. And when that happens, heartburn can happen. The things that relax it is basically nicotine, caffeine, chocolate, peppermint, alcohol. So all of those things can contribute to heartburn significantly. Then, of course, if your stomach is full because you ate supper late in the evening, it's more likely to kind of reflux, especially when you go to bed. And then Priscilla mentioned pressure causing reflux to happen. The main cause of pressure is actually obesity. If you're overweight, you squish your stomach, and the liquid can only go in two directions. It has to go up or it goes down. Then because of the physics of your esophagus, if you're upright, I think Priscilla also mentioned, you're less likely to have heartburn. So one can turn that to one's advantage by literally elevating the head of one's bed. And we'll go over a couple of ways to do that. And then finally, of course, if you're wearing tight clothing and you're squishing your stomach, then once again, it has to go somewhere. There are a few drugs that sometimes contribute to heartburn as well. All righty. So I was just wanting to review some of this stuff for the data because it actually gives us quite valuable insights in general. So this is a study of 10,000 nurses who were followed for about 25 to 30 years. To get into the study, they had to basically be healthy and not have heart disease or cancer. Every 4 years, they'd send them like 200 questions about their diet, their lifestyle, and their diseases. And they followed these nurses for 25 years, and it's an amazing data set, and there are tons of publications based on it. This particular slide looks at the effect of body mass index. So that's a way of factoring in your height and your weight. A normal BMI is basically 20 to 25. If your BMI is above 25, if it's between 25 and 30, you're considered overweight. If it's over 30, you're considered obese. And the nice thing about this study is they had a lot of people, 10,000 people, and then they made statistical adjustments for other things that can contribute to heartburn. So they made statistical adjustments for the people's age, whether they were diabetic, whether they smoked, their physical activity, their calorie intake, alcohol intake, coffee, tea, chocolate, using hormone replacement therapy, blood pressure meds, and even asthma. And I've highlighted in red at the bottom, these are things that we know contribute to heartburn. So they adjusted for that to try and just look at the effect of weight. So what you can see, I hope, is that basically as the BMI goes up on the horizontal scale here, the odds ratio or the risk of heartburn whizzes on up to almost threefold. The other thing that I find very interesting is that the upper limit of normal is 25, which is here. So even if you're up the upper limit of normal, the risk of your having heartburn is about 38% increased. So even within the normal range, as your BMI or as your weight goes down, your risk of heartburn goes down. So basically, if your BMI is down at about 21, you're about 30% less likely to have heartburn. And if it's down around 20, you're about 33% less likely to have heartburn. So this shows that even within the normal range, weight is important. All right. Then the other thing, as I said, they followed these nurses for 25 years. So they were able to look at their change in weight and whether that changed their likelihood of having heartburn. So here now on the horizontal scale, it's the change in their BMI. No change, plus means they gained BMI or weight, minus means they lost BMI and weight. And so what you can see here, they adjusted for the same things. As there was a plus, an increase in BMI, the risk of having heartburn increased by 13, 26, and almost more than 2.5-fold as the BMI went up. Conversely, in nurses who lost BMI or lost weight, the risk went down by almost 25%. So this once again helps us to realize, yes, this is causal. When they change the weight, their likelihood of heartburn changes as well. Well, it would beg the question, well, if I advise a patient to lose weight, then will that make a difference? There were a bunch of studies, but I just thought I'd limit it. This is a cool gadget that we use. Actually, to be honest, it's not a lot of fun for the patients. This actually measures the acid in the esophagus. Basically, you walk around with this thing, and it's like a little tube that goes up around your ear, in your nose, and down it goes, and it basically dangles at the end of your esophagus. And it's a pH probe. So it literally measures the acid in there. And so what we do is we get the patients to do that for 24 hours. And we make a big deal. We say, look, yes, we know it's a bit uncomfortable, but you got to have a normal day, because then we're going to look and see if there's acid in here. And so if they go home, they don't eat, then the test is meaningless. But anyway, I personally do this very rarely because, to be honest, it's not a lot of fun for the patient. But it's great for research studies because you're going to actually see if there's acid in the esophagus. So doing that, for example, they looked at 23 more obese people who basically used diet and lifestyle to lose weight. And they lost about 11 kilograms of weight. And then they did pH studies. And what they found is that when they lost weight, the amount of time that their pH in their esophagus was acid, the total time went down, and that was significant. And also the amount of time spent in reflux in minute went from 12 minutes down to 6 minutes. So here's an actual study where they had patients lose weight, looked at the acid in their esophagus, and they showed that it worked. But fortunately, we don't have to do that most of the time because it's not a lot of fun getting it measured. But of course, the question is how do I lose weight? Now, I know Dr. Curnew is quite a fan of Ozempic. You've probably heard of that. That's being used a lot to lose weight, but that's probably only a short-term thing. Can diet and lifestyle work in losing weight? So here's actually a fascinating study that was actually done in New Zealand, in a rural community in New Zealand, in a family practice. What they did is they wanted to see if a plant-based diet would work in people who had an elevated BMI or high cholesterol. So they took 65 patients in rural New Zealand, aged 35 to 70. To get into the study, they had to either be overweight or obese and have either diabetes, heart disease, high blood pressure, or a high cholesterol. They randomized these 65 patients because that's how we prove things in medicine. We do a randomized study. Either just do what your doctor tells you, normal care, or a plant-based diet. You're allowed to eat as much as you want, and whenever you go completely plant-based, you need to take a bit of B12. So they randomized these people for 6 months, and after 6 months, because all the normal care people wanted to try this diet too, they offered it to them too. So what did they find? Well, here are the changes in weight in this study. This is called a broad study. It's quite a famous study, actually. So basically, yes, in the control group, do what the doctor tells you, the weight went down a bit. But in the intervention group, the plant-based diet, it went down a lot. What's a lot? Over 10 kilograms. This is actually the highest degree of weight loss in any study that they've done randomized where they didn't restrict people's food intake. So they were allowed to eat as much as they wanted, And even so, on a plant-based diet, they lost over 20 pounds because 10 kilograms is well over 20 pounds. Not only did they lose weight, they followed these people's cholesterol. In the control group, yes, the cholesterol went down from 5.5 to 5.2, but in the intervention, the plant-based group, it went down even more to 4.7, and that was significant, as is shown by green. So they significantly lowered their cholesterol. HbA1c is a very cool blood test. It basically, it doesn't just tell you your blood sugar today, it averages your blood sugar over the previous 8 weeks. And so they followed that in this study. And it's probably a little hard for you to see, but the green people, the control group, where it's just do what your doctor tells you, the A1C went up. But in the intervention group, the yellow, the A1C went down. And that difference was significant. So basically, diabetic control also improved with this plant-based diet. Even more interesting, at least in my opinion, is the number of medications that people had to be on. So basically, in the control group, they started off all of the patients, total number of medications, if you added up everyone's medications, there were 74 prescriptions. 3 months later, there were 82. 6 months later, there were 80. But in the plant-based intervention group, the total number of prescriptions for all the patients went from 94 to 74. And you remember I said they extended that out to 12 months? It went down to 67. So not only did these people lose weight, but they were able to get rid of, what's it, 67, 70, 80, 90, about 27 prescriptions got canceled. So this losing weight has huge implications on your medication use. And even more interestingly, they looked at hanky-panky, by which I mean who followed the diet and who didn't. So a dietary indiscretion is when you didn't follow the plant-based diet. So they looked at how many not following the diet episodes people had over 3 days. And basically, the more episodes they had over 3 days, the less was the reduction in their weight. So basically, more hanky-panky on diet, less weight loss. So once again, it shows that it's the diet that does that. So that's really interesting. And here's an example from the study of the foods that they had people eat. So basically, if it's in the ultra green, you can have unlimited amounts of spinach, beets, kale, bok choy, broccoli. Lots of greens, have tons of vegetables, fruits, whole grains and stuff. Go a little easy on salt, sugar, processed flour even, and especially be careful about poultry, fish, meat, eggs, dairy products, and oils. So, you know, like I say, this is the broad study, and this is the foods that they were told that they should either avoid in red, or the foods that they should take. All right. Now, a common thing in people who are overweight, of course, is type 2 diabetes. And so a reasonable concern is, well, my goodness, is this plant-based diet safe for people with diabetes?
Okay, so you're having...
Actually, what got me into this whole food is medicine thing is that I was pre-diabetic, oh my goodness, about 8 years ago. So I was desperate to prevent type 2 diabetes. So here, for example, is a study where they took 99 people who already had type 2 diabetes. They were on, if they were on medications, they were on them for at least 6 months. And this just shows that they had moderate control of their diabetes. They randomized these 99 people, actually initially 22 weeks, but they ran it for a year and a half, for 74 weeks. They randomized them to one of 2 diets for these 99 people with diabetes. Either they put them on a vegan or a completely plant-based diet, which was low in fat as well. They encouraged them to take a diet which is low in something called glycemic index, and they allowed them to eat as much plants as they wanted. They could eat as much as they wanted. And as I said, if you're on a plant-based diet, you need to take 2 milligrams of B12 a week to protect your nerves. The other half of the patients, they randomized them to this, were on what's supposed to be the best diet, the American Diabetes Association diet. But interestingly, in this group who were following the standard American Diabetes Association diet for diabetics, if those people were overweight, they restricted their calorie intake by somewhere between 500 and 1,000 calories a day. Now, those of you with a medical background, and I can see some people in the audience will point out, this is not quite a fair study, because the people who took the Diabetes Association diet were calorie restricted, whereas those who were vegan were not. So it's true, it's not quite equal, but the benefit is to make the American Diabetes Association diet look better because they were calorie restricted. So like I say, if anything, this study was skewed to make the American Diabetes Association diet have better results because they had less calories. They ask people, don't change how much you exercise. They have small group meetings because that's what it takes for a lifestyle intervention to work. Okay, so 74 weeks and 99 diabetics, what do they find? Here's this HbA1c that I told you about earlier, the blood test. that averages your blood sugar for about 8 weeks. So it takes a while to change, but what you can see is it started off pretty equal at the beginning. It ran it for 74 weeks, and after about 12 weeks, you see that these two curves of HbA1c, they separate. And you can see the conventional group, which means the ones on the American Diabetes Association diet, their HbA1c was higher for the whole of the rest of the study than in those on the vegan diet. Those two lines stayed separated. So those in the plant-based diet had a lower A1C basically for the rest of the study. I think I mentioned to you that I was a pre-diabetic. So when I saw this, I was thrilled because a conventional diet doesn't really work at preventing diabetes, but this did. So I was actually, here we go, here's a bit more data. So here's the actual change in the HbA1c, which is basically 0.4%, which is fairly, it's almost as much as any diabetes pill will do for you. Here's their change in the weight of these people and their body mass index. While the change in HbA1c was significant, there was a bigger change in weight in the vegan group, but it didn't quite reach significance, but it was bigger. So that's also in the right direction. Changing in lipids, for example, Dr. Curnew checks cholesterol and LDL. There was a bigger change in total cholesterol, by which I meant it went down by more. And there was a bigger change in LDL cholesterol that went down by more in the vegan group than in the American Diabetes Association group. So in conclusion, while both the low-fat vegan diet and the American Diabetes Association diet resulted in some weight loss, when you control for medication changes, the vegan diet is more effective to control blood sugars and cholesterol as well. And in medicine, we have often when we find one study works, we want to do multiple studies. And now there's a way you can combine the results of multiple studies. That is called a meta-analysis. So this is a meta-analysis or a summary of 1, 2, 3, 4, 5 different studies. And basically what it shows is basically this vertical line here that says 0 means no effect. The little diamond is the combined effect in all the studies. And as long as the diamond doesn't cross the line, you know you have something significant. So what this shows is that when you combine each of these studies, the diamond doesn't cross the line. What this shows is overall in all of the studies, all 5 studies when combined, there is a drop in HbA1c of about 0.4%. So this once again proves with all of these being randomized studies that we can control diabetes better with a plant-based diet than we can with the American Diabetes Association diet. And so I think it's a pity that this isn't now the standard of care. For example, this was me as a pre-diabetic. This was me after I'd been dragged kicking and screaming into a plant-based diet, but I was happier and I still am. So there's the proof of the pudding being in the tasting for what it's worth. Just a gentle reminder that if people decide to adopt a plant-based diet, firstly, you need to take B12, like I said, 2 milligrams a week. Secondly, it can actually reverse diabetes and even heart disease, and so your medications might need to be changed by your prescribing doctor. After I did this for a few years, I got so excited that I actually built a website called foodasprevention.com, where I explained this to my patients about how you could adopt a plant-based diet and how it could help these conditions. I'll talk about that a little more later, but actually I now run a program to help patients with heart disease responds very well, high cholesterol responds very well, diabetes responds very well. So I run a special program for patients who want to try this for 6 months. And actually I've treated quite a few of Dr. Curnew's patients as well as other doctors' patients. And to be honest, sometimes the patients are so happy they're just about dancing in the examining room because they feel great too. Anyway, I digress. Let's get back to stopping heartburn. What about stopping smoking? So here's a study where they took people, this was a population-based study from Norway, where they followed people for about 10 years, 29,000 people, who said they had heartburn or acid in their stomach. And they asked them, how bad are your complaints from heartburn? And they basically tracked those who smoked and didn't. And they looked at those who said, if they went from major complaints from heartburn to minor or no complaints, that was considered success. So what they found is that in those people who quit smoking overall, there was about they were 1.8 times as likely to have improvement in their heartburn symptoms if they quit smoking. But what I find particularly interesting is they broke this down by BMI, which is how overweight they are. For the people who had basically a normal BMI, 25 or less, they were 5 times as likely to have improved heartburn if they quit smoking. But as the BMI went higher to 25 or more than 30, it became less significant. So this basically suggests that if you're a smoker and you're not overweight, it will probably respond. But if you're overweight, that gets a bit more difficult. And they adjusted for all of those things on the bottom. What about diet itself, you ask? Because people often ask about diet. So here was one study where they basically tried to look at the association of heartburn with specific components of diet. So they looked at 900 employees in the Veterans Medical Association. That's a US ex-military people down in Houston. They offered to scope everyone. Well, some of them took them up on that. And they looked at 28% or almost a third of these people had heartburn already. And they analyzed their diet to see if diet predicted the likelihood they've had heartburn. And I've highlighted in yellow some of the things in diet that did predict heartburn. Basically, if you look at GERD symptoms versus no GERD symptoms, the total calorie intake was higher in those who had GERD symptoms. Didn't quite reach significance. It was 7% instead of 5%, but it's going that way. Total fat was also higher, 77 grams a day versus 68 grams. That was significant. Saturated fat was higher at 23 versus 20 grams. Amount of energy from fat was higher. 40% of their daily calories came from fat, as against 30. The average Canadian diet is 30 to 35%. And interestingly, fiber there's a trend to being protective. Those who had the higher fiber were less likely to have heartburn. So that gives you a bit of an insight on diet and heartburn. I had a bunch of other studies, but I didn't want to tire people out. And interestingly, when they broke down food groups, you can see that when it comes to meat, basically those who had no erosions are like ulcers in the esophagus. Those who had no erosions had 2 portions of meat a day, but those who had ulcers in their esophagus from heartburn had 2.4 servings of meat per day. In other words, more meat went with ulcers in the esophagus, and that was also significant. What about the time that you eat? So here was an interesting study. They took 30 people and they got them to eat a meal either 2 hours before bedtime or 6 hours before bedtime. And then they basically put actually a different way to monitor acid. They actually clipped a little acid probe to the middle of their esophagus and they had them lie down and they looked to see how much acid there was after basically a high-fat stress meal, which actually ended up being a Big Mac, medium fries, and basically a diet pop. So here you're looking at the amount of acid in someone's esophagus, whether when they lie down 2 hours after eating or 6 hours after eating. So when they're upright, standing up, there's no real difference in the percentage of time they have reflux. But when they're supine means lying down, you can see that the late meal people had way more reflux than the early meal people. That was significant. So yeah, the time of day you eat makes a difference, and specifically how long between supper time and bedtime. Other interventions is elevating the head of your bed. So here was a study where once again, they had patients elevate the head of their bed and they looked at heartburn symptoms. So what they did is either they had patients lying flat in a regular hospital bed, they used a 2.5-foot wedge that was 10 inches high, like this in this bottom picture, or they literally lifted the legs of the head of the bed up on 8-inch metal cones. So the whole bed was at an angle. And they looked to see what that did in terms of acid in the esophagus. So here you can see how much time there's acid in the esophagus was less with a wedge or with blocks than it was with a flat bed. And then here, the number of reflux episodes, as you can see, it went down with a wedge, but it went even down with blocks under the head of the bed, which makes sense because the whole of the bed is now at an angle. So I'll tell my patients to get either Harlequin romances or 2x4s and put them under the legs at the head of their whole bed. So the whole of the bed is at an angle. So here we can see, for example, summarizing some of this, heartburn increases with your BMI and with your weight. And in obese people, if you lose weight, you can decrease the amount of acid. And also in non-obese people, we saw that correlates. Stopping smoking works best if you're not obese. Dietary factors include fat, being on a non-vegetarian diet, which is a bad thing, the meat. Low fiber is also bad. And for nocturnal reflux, the time of day you eat, I didn't actually show you the data on hiatal hernia, but there's evidence saying that a hiatal hernia makes it worse. If you're overweight, it makes it worse. And of course, the angle of the bed. Oh, and then finally, yes, tea, coffee, and caffeine. This was actually a fascinating study. So they wanted to see the effect of different drinks on the acid in people's esophagus. So they took 16 people who didn't have heartburn, and they gave them a standard breakfast, and they randomized them to either have regular coffee, decaf coffee. Coffee has more caffeine than tea. So they diluted the coffee so that it had the same amount of caffeine as tea. And then they took decaf tea, and then they took tap water, and then they checked the acid in their esophagus. And what, for example, here's the amount of caffeine in each of these people. So here you see coffee is up at about 0.7. Decaf coffee has very little. The diluted coffee, they diluted it down to the level of tea. So it's 0.7 versus 0.4. Tap water has none. And then they actually added caffeine to tap water to see if just the caffeine alone did it. So that was kind of interesting. So what did they find? So here's the amount of time acid in your esophagus with regular coffee, decaf coffee, and water. So here you can see there's an improvement with decaf coffee, but it's worse than water because those are significant. Then here you can see the amount of acid with normal tea, decaffeinated tea, and with water, and those are all fairly low. And then here is this diluted coffee, and as you can see, even when you dilute the coffee, it's still worse than normal tea. So in terms of the effect on your esophagus and acid, regular coffee is worse than decaf coffee. Decaf coffee still has a problem, and is worse than decaf tea or regular tea. And so basically there's something else in coffee besides the caffeine. So that's why decaf coffee can be a bit of a problem. Caffeine alone, interestingly, didn't show heartburn. So yeah, if you're a coffee drinker and you're having heartburn, either go decaf or even better, go to tea or stop all the caffeine, which is a good time for us to pause and let people ask some questions. Hopefully we haven't sent everyone into a coma.
I actually have a question, Dr. Ganguli.
Yep.
I guess in some of the previous webinars that Dr. Curnew and I have done, I think we talked a little bit about coffee as like a superfood, and I don't know if Dr. Curnew, you're here to chime in on that. Is there, I guess, I know that last sort of slide you shared with us is saying that, coffee and like something in coffee, not the caffeine, but something in coffee is, putting, or it can cause this heartburn or the heartburn symptoms. Is there like a safe amount of coffee, or should it just be, if people are having heartburn, should they just completely cut it out? Or I guess, what are your thoughts on that? Because I know there's some benefits to drinking coffee as well.
Yeah, it's a complicated thing, really. You're right. Obviously, if you don't have heartburn, then coffee is absolutely fine. If you do have heartburn, they actually did a study in Sweden that showed that people who have heartburn 3 times a week or more have an increased rate of cancer of the esophagus. So I think the important thing is that if you do have heartburn, it's important that it be controlled. And control of heartburn is preferably once a week or less. So I think the key is to get it controlled. But if you don't have heartburn, then yeah, there are some benefits. Like coffee, they say it can be good for fatty liver, and it can be good for other things as well. So that's a great point, Daniel. Does anyone else have a question or a comment? Maybe Dr. Curnew has something to say.
One of the things that is I wish more people would, go to things like the broad trial and other trials and make those changes. People find them very challenging and very difficult. But I find that, you can find really success if you work with groups of others. And I'd be curious to see how people can find ways to do this. Because you're right. When you said to me, is that the body's not happy when it gets this heartburn. There's a lot of medical issues there. And Priscilla, I like your explanation. Then one of the things that we rely so often on PPIs, these medications, then they do have side effects. And I'm wondering, Dr. Ganguli, do you want to just review some of what your thoughts on long-term effects of PPIs?
Yeah, that's a really good point, Greg. There are some long-term side effects of PPIs. Actually, I've got a slide on it here. Let me just pop up that slide so you can see it, because I have to admit, as the years go by, I become more aware of this stuff. So here's a slide that talks about some of the possible side effects of PPIs. So basically, it's very rare that it causes acute kidney injury, but it can, I think probably less than 1 in 1,000. There is about a twofold in people. Okay, stomach acid does 2 things. Well, it does a lot of things, but A, it helps kill bacteria, and B, it helps you to absorb calcium. So the PPIs decrease stomach acid. That's how they work. You'll never get rid of that. So they found that since stomach acid kills bacteria, people who are on chronic acid suppression have about a 2-fold increased risk of getting a gut infection. And one of those is called C. difficile, and it can be quite nasty. The other thing is that stomach acid helps you absorb calcium. And I know there was one study that showed that people on PPIs for 7 years or more had an increased rate of bone fractures and osteoporosis. So the practical takeaway on that, especially in Canada, is you need to make sure that your vitamin D level is normal if you're taking PPIs, because vitamin D has a huge role to play in preventing osteoporosis. I think the other associations are actually minimal. Like theoretically, it can affect B12, but it's not clinically significant. And that's the same with magnesium. And the other stuff isn't really proven. So yeah, like I say, it's one of those things. That's why it's important to address the cause of your symptoms and to address lifestyle as much as you can. And I can't personally understand, people seem to fall on a spectrum of how willing they are to address the cause. But that's a great question, Greg.
I mean, I always appreciate that picture of you, the before and after the change. And so my before and after is still a work in progress. And is that but saying that is that all the things that you were talking about, to me, the downsides of PPR is this bone issue about avascular necrosis, the femoral head that can appear. And then, you need acid in your stomach to protect you against infection and things of that nature, and you get sick as well. So that could be an issue too as well. So I would rather have food as my medicine rather than as pills as my medicine. And I think you have to think about, how to make this work. I know it's hard, but I think you showed some good solutions about that. And Priscilla, you're going to have to help us all farts do a better job at managing these things, because a lot of people are struggling with this. And so thank you for sharing that.
Cool.
Hi, Dr. Ganguli. Can you hear me?
Yeah.
My name is Anil, and I have a question. First of all, I just want to say big thanks to you and Dr. Curnew's team. This is very informative. I was just diagnosed 3-4 weeks ago with the Barrett's esophagus. And they told me to change my lifestyle, which I'm not drinking tea, coffee, and wine, alcohol anymore. This is the 3rd week. My question is, this PPI, how do I know after 2 months or 1 month, let's say, if I don't have any acid, do I have to continue with the PPI for the rest of my life, or I can change my lifestyle and go without medicine?
Yeah, that's a really tricky question. If you used to have heartburn and you don't have it anymore, presumably you've got a degree of protection. But yeah, that probably depends on what they found when they scoped you. Some physicians like to keep their patients on acid suppressors long term, whereas others of them, like I say, the question is can the patient tell if they're having heartburn or not? Most people can feel heartburn, but there is a subgroup of patients who no longer feel their heartburn. And it's those patients in particular where it's very, very tricky, especially when they have a precancerous condition and you want to minimize the damage. So that's a great question to discuss with whoever it is that gave you that advice. And like I say, yeah, I don't know if you have heartburn symptoms or have had them in the past or not, but it's a good question. But, once again, having a diet, they actually did a study with frozen strawberries, like strawberry extract in people with Barrett's. And they basically found that things like blueberries and strawberries can actually be partially protective. That study, if you go to nutritionfacts.org, and if you look in the search box, that's a website by a real food as medicine geek. And he has over 2,000 videos about food as medicine. So yeah, if you just type either Barrett's or strawberries, you'll see this 5-minute video come up that explains that. But yeah, take lots of antioxidant fruits as well. But yeah, avoid, go on as strong an anti-cancer diet as you can. The guy who made that website has a book called How Not to Die. His name is Dr. Greger, Greger. That will guide you to a diet that will help your esophagus and the rest of you. Great question.
Thank you so much, Dr. Ganguli.
Yeah.
Well, there's other things that we answer that question. There's H2 blockers. We used to use pills like Zantac, which are weaker agents and things of nature, and they have less propensity for side effects. Where do they fit into this scheme of things? I'm just thinking for Anil here, if he wants to use something that's less strong, does that? And then we also have these red flags too, as well: weight reduction, anemia, different. When you want to go what are some of the red flags that say, listen, is that I'm more worried about you. You might have, let's say, cancer, some other problems, or or this might be more serious. So do you want to just review that with us as well?
Sure. So when people have heartburn, the red flags that something nasty might be going on is, does food stick when you chew or swallow? Do you have pain with swallowing? Have you lost weight? Do you have abnormal blood work, such as being anemic? All of those are absolutely red flags. Yeah. Yeah, I mean, the general principle is you want to use the safest drug that controls a patient's symptoms. Now, the two problems with H2 blockers, ranitidine being one of them, famotidine being another one of them, is A, they tend to be fairly mild, like they're not as potent as PPIs. Secondly, they exhibit something called tachyphylaxis, which basically means we get habituated to them. They lose their effectiveness. So, you know, being on a quote safe drug that isn't working versus being on a, you want the drug. So as you say, you basically, it boils down to the individual patient, and you have to tailor it to that individual patient to make sure that they're getting you don't want them to be overtreated, but you don't want them to be undertreated as well. So it is, yeah, it has to be personalized. But yes, they, as you say, for people who have mild symptoms or intermittent symptoms, H2 blockers can be a reasonable alternative, because the plus of H2 blockers is they work fairly quickly. So if someone only gets heartburn 4 or 6 times a year, or maybe even once a month, yeah, and if they find that popping a couple of ranitidines or famotidines work, then that's fine. And even antacids, as long as these symptoms are rare, I mean, or Gaviscon, that can work as well, but you just don't want to be taking it too often, because it actually gets expensive also.
The other thing too is that some people, there's different PPIs available. There's trial and error, and once a day, twice a day.
Yep.
Is it better to give it just in the morning time? Is it how if you're going to use these medications, how do you use them smartly, and when do you use a higher dose? And
Absolutely. And once again, it boils down to the individual patient. It has to be tailored to the individual patient. The standard guidance used to be either take them once a day or twice a day. They always work best when they're taken before a meal. So the way to most effectively use PPIs is 30 minutes before a meal. And they also, the effect builds up over about 5 to 10 days. So basically, if the effect of someone who just takes one pill on a Monday is much less than someone who takes one pill every day for a week. So once again, you have to tailor it to the individual patient. So if someone's having heartburn 4 to 5 times a week, then they probably need to be taking a PPI every day. But if they only have intermittent heartburn, then they may be able to take the PPI intermittently. But like I say, you absolutely have to tailor it to the patient, and that's why you have to discuss it with your prescribing physician, because no one wants to be on more medications than they need to be. But conversely, we don't want people on less medications either, because we don't want to inadequately treat something. Because as we said, Swedish studies have shown if you're having heartburn 3 times a week or more, your risk of cancer goes up. So you have to tailor it to the individual. You're muted, Greg. Sorry,
Priscilla, I really loved your explanations and your graphs and your pictures about what's going on at the at a more in-depth level. What's your thoughts? What when you see people with reflux and or trying to figure this out, what are some of the pearls you have for people that you've picked up along the way?
Yeah, well, I'm very early in my career. I'm not even a resident yet, but I think one thing I have seen is that people haven't tried a lot of the lifestyle modifications that Dr. Ganguli did go over. And it's not just with GERD, it's with like so many different things like cholesterol and diabetes and basically like everything. I think it really undermines the value and the importance of lifestyle modifications in combination with pharmacological therapy. Yeah, I think it's important to at least try, modifying, like, for example, the position thing, like sitting up and or not lying down right after a meal, like, or eliminating certain foods from the diet. It's important to at least try to use those, because a lot of the times those are actually targeting the cause of the symptoms as opposed to the symptoms themselves. So yeah, that's my 2 cents on that.
Well said, well said.
So we're about halfway through. Should we do the
Yeah,
colon cancer part?
let's go on to part 2. Thank you so much. That
Okay,
was wonderful.
Priscilla, you're off to the races on colon cancer.
Okay, can everyone see my screen?
I can.
All right. Okay, so next topic is colorectal cancer. And again, we'll start with some anatomy here. So colorectal cancer, from the name, it includes two parts of the gut, which is the colon or the large intestine, and then the rectum, which is this vault at the bottom here that holds stool before we pass it out or defecate it. So that's kind of the areas that colorectal cancer can occur in. And when we're talking about the colon, there are a few different parts. I just want to go over it quickly. On the left, we see the ascending colon, or the part of the large intestine right at the outermost area. So that's called the ascending colon. We then see the transverse colon. That's the part that goes kind of across. And then we see the descending colon going down on this patient's right side here. And then we also see the sigmoid colon right at the end, which connects to the rectum. I do just want to clarify. So when we're actually looking at real anatomy, so if we're feeling where our own descending colons are, that's on our left side, but in the picture, it's just on the right side. I hope that makes sense. Okay. So what exactly does the colon do and the rectum? So the colon is responsible for absorbing a lot of water, and it absorbs a little bit of a few nutrients as well, things such as salt, but that's mostly the job of the small intestine. So the colon is mainly responsible for absorbing a lot of the water, and once it has done this, the remaining contents that are traveling through the gut will travel through to the rectum, and then it's kind of held in the rectum until we are ready to defecate or poop. And then once that happens, it will go from the rectum into the anus and you poop your food out. Okay. So this is kind of just further reinforcing that. The anus is the end of the tract, and it's kind of the area where the stool is just prior to leaving your body. So there's sphincters here, like I mentioned in the last talk. Sphincters are the kind of these muscular parts of the tissue that pinch. And so when we're ready to poop, the sphincters can open and let out the poop. Okay. So polyps, this is kind of where colorectal cancer starts sometimes. So yeah, most colorectal cancers will start as a polyp, or this kind of bulging growth on the inner lining of the colon or the rectum. Now, some types of polyps are not cancerous, so we don't have to always get worried when we hear about a polyp, but then there are other types that can turn into cancer or are cancerous themselves. And the risk of a polyp turning into cancer really depends on the type of polyp it is. So there's different types here, as we can see. There's adenomatous polyps, hyperplastic polyps, and then serrated polyps. These are all really big words, but basically they're just used to classify the different types of polyps that a gastroenterologist sees when they put a scope up the bum and look at the polyps inside. So it's a way that we classify it. Some polyps, like I mentioned, tend to be cancerous or can lead to cancer sometimes. So that's usually the adenomatous polyps and then the serrated polyps sometimes. Hyperplastic polyps are usually not precancerous. So that's the general gist of the types of polyps that may or may not turn into cancer. Okay, so what are some risk factors that lead to polyps developing into cancer, or what are some risk factors for that? So if a polyp is larger than 1 centimeter, that is a little bit concerning. If we see more than 3 polyps on the scope, And then also sometimes they will take a little piece or a little chip or biopsy of that polyp when they do a scope, and they'll test it. And if they see changes in the cell structure or something we call dysplasia, that can also raise some flags for concerning or cancerous polyp. So sometimes they will take a little biopsy or a little piece of that polyp and kind of send it for testing to get an idea of what, if it's dangerous or not. So if someone does have colon cancer, what happens is it will start growing in the colon. It will start off as that polyp, and then it can keep growing. And you can see here that it can really invade the walls of the bowel or the guts, and it can spread outside. Sometimes it can lead to something called a perforation, which is when it penetrates through that bowel wall, and that is dangerous because then all of that, all of the stuff in our feces kind of breaks through and enters into the abdominal cavity. So that's not a good thing. Okay. And just briefly, the types of colorectal cancer we see usually is adenocarcinomas. So this is the type of cancer that actually arises from cells in our colon that make mucus. So this mucus, we kind of talked about mucus earlier as well in the stomach lining. The mucus here helps to lubricate the inside of the colon and rectum. So again, an important function of these cells. And these cells are usually the ones that can become cancerous sometimes. There's other subtypes of the adenocarcinoma. So there's basically different types of cancer that have different prognoses or different levels of danger, essentially. So for example, something called signet ring or mucinous adenocarcinomas can be a little more dangerous than other types of adenocarcinomas. So what are some of the symptoms that people may see if they have colorectal cancer? Colorectal cancer can be a very slow-growing type of cancer. And so sometimes a long time passes, or that polyp grows really big before someone starts experiencing symptoms, which can actually be really dangerous because it's hard to catch it early unless they've been getting scopes regularly. Sometimes what we'll see is symptoms dependent on where the cancer is. So as I mentioned, our right colon is on, the ascending colon is on the right side of our body, and then the descending colon is on the left side of our body. And the descending colon is closer to our rectum, which is where we poop out, rectum and anus, which is where we poop out the feces. So if there is cancer in the right side of the colon, sometimes it can cause bleeding. But what happens is we don't always see bright red blood in our poops because it takes time for that feces to go from the right colon across the transverse colon, then into the descending colon. So sometimes we may not see frank blood, but we may feel it through symptoms such as fatigue or weakness because we're losing small amounts of blood every time we poop because that cancer is causing blood loss. And then sometimes if the cancer is on the left side, which is closer to the rectum and the anus, as I mentioned, we may actually see bloody stools because that blood doesn't have time to dry up or disintegrate. It kind of quickly passes from the descending colon right into the rectum, and then it's pooped out pretty quickly. Sometimes it can lead to perforation, which I mentioned is kind of the cancer growing and creating a hole in the bowel wall. And then it can lead to obstruction as well. So if it grows big, it can prevent the feces from really passing through the bowels and getting through. So an obstruction or a blockage may result from that. Okay, so what do we do when we suspect that someone may have cancer, colorectal cancer? So two of the tests that we do that can lead to a colonoscopy would be the fecal occult blood testing and FIT. These are both stool studies that test for blood in the stools. And that can tell us if someone is bleeding, even if they can't see it in their blood, if there's trace amounts of blood that are in the stool that may be suspicious for a colon cancer. And if that does happen, then the person can have a colonoscopy as well. So as I mentioned earlier, this is a procedure in which a tube with a camera at the end is stuck up the bum, and it helps us to identify any unusual polyps or any cancers that may be present in the colon or the rectum. And then sometimes people have genetic testing as well, because there are some conditions that can predispose a person to colorectal cancer or lots of polyps in the bowel. And so that would be important to get tested for that. Something that helps to prevent colorectal cancer from going too far, or help doctors catch it early so that we can treat patients as soon as possible, is screening. Screening depends from province to province, but in Ontario, we kind of classify screening based on the risk that the person has of colorectal cancer. So for average risk people, which are most people that are between 50 to 74 years old with no family history of colorectal cancer, they may get a flex sigmoidoscopy every 10 years. What this is it's kind of like a colonoscopy. So it is a version of kind of that tube with a camera being stuck up the bum to look for any pathology, but it doesn't go as far up the bowel as a colonoscopy would go. So it's a little bit different. And then we also have the FIT test that people do. And as I mentioned, if there are abnormal results, that would trigger a colonoscopy being done. For people who are at increased risk, so this would be people who have a family history of disease or possibly a gene that predisposes them to cancer, we encourage them to get colonoscopies every 5 years if they are someone that has a first-degree relative that was diagnosed before 60 years old. So if I had a relative, or if my one of my family members that was first degree was diagnosed before 60, I would start getting my colonoscopy every 5 years, 10 years before their diagnosis date. So for example, if I had a family member diagnosed at 50 years old, I would start my screening at 40 and I'd get it every 5 years, if that makes sense. And then it's every 10 years for people with a first degree relative who were diagnosed with their colon cancer at the age of 60 or older. Okay, I'm just going to skip over this part because Dr. Ganguli will go over it later. We'll go into treatment now. So treatment can be sorted out into surgical and then medical treatment. So surgical therapy can be attempted for patients where the cancer has not spread too far yet. If it spreads, surgery would not be very successful. And so what happens is if the colorectal cancer is localized to a part of the bowel, it's resected, or it's that area with the cancer is taken out, it's cut out. And we also take out some of the lymph nodes that are attached to that area as well. And then what they do is they kind of glue the ends of the remaining colon back together. So that's called anastomosis. And you can see that in the third picture here, the bowel has been glued together. It's a little shorter, but it's stuck together. And then we also have medical therapy or chemotherapy. So there's a regimen called FOLFOX, and this would be given by an oncologist. And it can be really successful and improve survival in patients. The specific doses and number of cycles that need to be done would be really dependent on the type of cancer and all of that. But there is chemotherapy available for colorectal cancer. Okay, so that's my portion of this. I'll hand it over to Dr. Ganguli.
So Priscilla, you mentioned a couple, Dr. Ganguli is getting his slides ready. You mentioned that there's fecal occult blood testing that's available, and there's colonoscopy. And what do you advise? When should you have colonoscopy? When should you have just a fecal test? And what, it's I'd be curious to see what your thoughts are about that.
To be honest, I've actually forgotten the specific screening guidelines.
Yeah,
Dr.
so basically, after the age of 50, everyone should have some sort of screening, Greg. And if you're not at increased risk, FIT is the way to go. But if you are at increased risk, either from a personal or family history of adenomatous polyps or cancer, then colonoscopy is probably the best way to go. But pretty much everyone after the age of 50, I think the province mails out these fecal FIT tests to everyone who is over 50, and doing them repeatedly is the way to go. So it's a bit stratified by your risk. Anyway, with that as an introduction, why don't I talk a bit about the lifestyle aspects of colon cancer. So they've actually done some huge studies to look at the effects on the risk of colon cancer, for example, of diet, because of course, all the food, or most of our food, actually goes through our colon. So if food is good or bad, it probably might, it's reasonable to think that it might have an effect on colon cancer. So rather than showing you hundreds of studies, I'm showing you results here. So for example, here, the risk, RR, is the risk of colon cancer. On the horizontal scale, it's the amount of whole grains that people eat, 50 grams a day, 100 grams a day, 200 grams a day. Up in the top right, this is basically a summary of multiple studies. N means how many studies, the little n is how many subjects. What this shows is basically as the amount of whole grains you eat goes up, your risk of colon cancer comes right down. And this is highly, highly significant. But what most people don't actually understand is what whole grains are. It's an unprocessed grain. For most normal humans like us, the simplest whole grain to get a hold of is quinoa. Pretty much every other grain that you're going to mention to me is processed, like wheat. Theoretically, whole wheat, yeah, you can get whole wheat, but it's actually like even whole wheat bread has regular wheat in it. But quinoa is a very good example of a whole grain. So with that as an introduction, let's look at a few other things. Vegetables, do those protect me against colon cancer? On the horizontal is your dose of vegetables. So remember, 450 grams is a pound of vegetables. So you can drop your risk of colon cancer by more than 10%. But you need to be getting over a pound of vegetables a day. Once again, that is highly significant. So the line goes down and to the right. That means the more, the better in terms of preventing colon cancer. What about fruit? Same as, again, the line goes down and to the right, and that is significantly more. So once again, once you hit about a pound of fruit, you decrease your risk by about 10% of colon cancer. What about eggs? Are they everything they're cracked up to be? Well, the line, unfortunately, with eggs goes up as you go to the right. An egg is about 50 grams. So even at one egg a day, you've got about a 20% increased rate of colon cancer. Not so good. That's significant. But moving on to meat, well, this is where it gets pretty extreme. So here, remember, an ounce is 28 grams. So here, this is 4 ounces a day of meat. 200 grams is 8 ounces a day of meat. So if you're having 8 ounces of meat a day, which includes breakfast, lunch, and dinner, kaboom, kaboom, you're up at about a 30% increased rate of colon cancer, highly statistically significant. But of course, there are different types of meat. So I'm talking about red meat would be a steak. So 100 grams leads to a 12% increase with red meat. Remember that, 100 grams, 12%. Why? Because processed meat, half of that amount, 50 grams, causes a 17% increase, way more potent at producing colon cancer. So there it just shoots up, and you can have like a 40% increase rate of colon cancer with just over 4 ounces of processed meat. What am I talking? Bacon, wieners, McDonald's hamburgers. Sorry, don't want to spoil anyone's supper, but it's a very strong relationship with processed meat. Why, you say? There's a bunch of things, but one of them is heme iron. What on earth is heme iron? Heme as in hemoglobin. So if it has red blood, it has heme iron in it. And so that, here you can see the dose of heme iron increases your risk of colon cancer. So we'll never make meat safe because meat always has blood in it. Well, is it a big deal? Look, I only have 3 or 4 portions of meat a day. What does 1 portion of meat a day do to me? So you remember I told you there's this huge nurses study? Well, here it comes again. Here they had 80 plus 87. So that's 160,000 nurses, 37 male healthcare professionals. To get in, they had to be free of heart disease and cancer. They get 200 questions every 4 years. This particular part of their study looked at the effect of meat consumption and diabetes on people. And how much is a portion of meat here? It's 3 ounces. It's less than an ounce of playing cards, because I've talked to you about meat and colon cancer, but what about other aspects of meat? 1 portion of meat is 1 hot dog or 2 slices of bacon. This shows people's meat intake. Q5 means quintiles. Quintiles means 20%. If you're on the top 20% of meat intake, you have a 44% higher chance of diabetes. I just told you about colon cancer. Now I'm talking about diabetes, and this is adjusted for all the usual stuff. So for men, if you're having 2 portions of meat a day, which is only 6 ounces of meat a day, you've got a 44% increase rate of diabetes. If you're a woman, you've got a 30% increase rate of diabetes. But as they say, that's not all. If you increase by 1 serving a day, now it's broken down by the type of meat. Unprocessed meat like steak, 12% increase rate of diabetes. Processed meat like wieners, 32% increase rate of diabetes. So once again, processed meat is particularly bad. That's diabetes, but we're not just talking about diabetes. Here, they're looking at different things. This is total mortality, the effect of increasing meat intake by just 1 serving a day. If it's unprocessed meat, your total death rate goes up by 12%. If it's processed meat like wieners, 1 portion a day, it goes up by 20%. But that's not all. Your heart mortality goes up by 17 to 20%. Your cancer mortality goes up by 10 to 15%. Sorry, but I find this depressing, but that's what just 1 portion of meat increase per day will do to you. Okay, let's move on. Dairy, oh my goodness. So with dairy, your risk of colon cancer goes down as you increase dairy. So that sounds good, but no, this is a huge amount of dairy. 1,000 grams of dairy is a liter of milk a day. 1,500 grams of dairy is 1.5 liters of milk a day. But you say, well, look, my risk of colon cancer, it's 0.7, it's 30% down. Yeah, but just wait a minute. Because yes, the risk of colon cancer with dairy products goes down, but unfortunately the risk of prostate cancer goes up with dairy products. So if you have a prostate, you might want to think twice about having more dairy. Why is that, you ask? Well, this is a summary. Here is a meta-analysis of calcium intake. It's probably the calcium in milk that is related to the increased rate of prostate cancer, because here are a whole bunch of studies, and the overall effect is there's a 15% increased rate of prostate cancer based on your calcium intake. So unfortunately, it is a very double-edged sword. And despite being a gastroenterologist, even I would have to admit that cancer of another organ is not real good. Okay, so summarizing what I've already said so far, here are the protective factors: whole grains, veggies, fruits, and dairies decrease your risk of colon cancer by kind of 10 to 30%. Red meat increases it by 27%. Processed meat increases it by 40%. So here you can see there's a whole combination of things that we can do based on this big publication to change this. And for example, they said, if you took 6 servings of whole grains a day, 6 servings of vegetables, 3 servings of fruit, and 3 servings of dairy a day, they said you drop your risk of colon cancer by 56%. That's pretty impressive. It's down to about half of what it should be. However, if you had 2 servings of red meat a day, remember that's smaller than a pack of playing cards, and 4 servings of processed meat, you'd increase your risk of colon cancer by 80%. That's called the wrong direction, increased risk. What about alcohol, you ask? Well, guess what? It's not good for us. Basically a straight line, and a drink of alcohol is about 10 grams a day. The more alcohol, the more colon cancer. Sorry. What about physical activity? Well, this is a meta-analysis again. The diamond doesn't cross the line. So exercise protects you against colon cancer, 20% decreased risk. What about being overweight, or BMI? Kaboom. Not only is it basically a straight line, at what BMI does it start going up? Hello, at the upper limit of normal, it's already creeping up at a rather nasty rate. So unfortunately, I think there's about 6 or 8 cancers related to being obese. It's not good for the point of view of cancer. What about my genes? I've been told that it's all in my genes. I came across an absolutely fascinating study of this. They basically had a score for how healthy people's lifestyle was, and then they looked at people who had colon cancer. And they took 4,000 people with newly diagnosed colon cancer. They took 3,000 people who didn't have colon cancer, and they did genetic analysis on them. And they were able to come up with a score based on 53 different genes on how high your genetic risk of colon cancer was. Then they did a score for how healthy your lifestyle was. What do you mean by a healthy lifestyle? Do you smoke? Do you abuse alcohol? Do you have a healthy diet? Are you physically active? And are you overweight? You could get a score between 1 and 5 based on how many of those things you did right or wrong. And so they looked at the gene risk and the lifestyle to see if lifestyle was protective in people who had a high genetic risk of colon cancer or a low genetic risk of colon cancer. And here are the results. The score could go from 0 to 5 for healthy lifestyle. So orange means you had a low genetic risk of colon cancer. And as you can see, as your lifestyle score goes from 0 to 5, your risk of colon cancer comes crashing down. But the interesting thing is even in the blue dot people, those are ones who had a high genetic risk of colon cancer. Once again, their risk of colon cancer came, whoopsie, crashing down the healthier their lifestyle was. So whether you have a high or a low risk of genetic colon cancer based on 53 different gene variants, lifestyle works. This is a huge thing that I never realized, because when I went through med school, they were going crazy about this human genome project and it's going to change the world and everything. And then they mapped the whole genome, human genome in the year 2000, and some good things have come out of it. But since then, we've realized there's a whole field called epigenetics, which is turning your genes on and off. And that is environmental, that is lifestyle. So lifestyle in many situations will trump your genes, which is good news. So just a reminder, take your B12 if you decide to go plant-based. So this is my Food is Medicine website for anyone who's interested. I do actually run a Food is Medicine program for people who want to do this for 6 months. I've seen a bunch of Dr. Curnew's patients actually, and we run small groups. That's what it takes to adopt a plant-based diet. So if you want to try it for 6 months, chat to Dr. Curnew or whatever. I don't have a dietitian, so if you're on warfarin, Coumadin, if you have kidney failure or you've had bariatric surgery, because I don't have a dietitian, I can't work with you. But everyone else, you know, if you've got heart disease, if you've got diabetes, this, that, chat with Dr. Curnew if that interests you, or just go to the website, check it out yourself. But remember, if you go plant-based, you need your 2 milligrams of vitamin B12 per week to protect against irreversible nerve damage, and you get your GP to check your B12 once a year. That's important. A good point to end at. Any questions? Greg, yeah.
Go back to your website. This is a fantastic website.
Oh, okay.
Everybody should. I think more people should spend more time on this over here. It's a fantastic thing that you've done.
Foodasprevention.com. Yep. So yeah, if you just go there, thank you, Greg. That's very kind of you. Basically, I've been collecting useful links for like 8 years now. But it tells you what to have for breakfast, what to have for lunch, for what to have for dinner, and it tells you what to put on your shopping list, and it tells you about heart disease and diabetes, and it basically tells you everything you need to know. And if you'd like some support, you can get your GP or Dr. Curnew to refer you to me, or if you prefer to do it at your own pace, it's basically there on the website. I actually have a whole page on supplements, but like I say, the essential one, don't forget, vitamin B12, 2 milligrams a week, get it checked once a year. It's dirt cheap, and that protects against irreversible nerve damage. But thank you, Dr. Curnew.
So one thing I want to remind people is that we have global warming issues right now, and the single most important thing you can do as an individual is change your eating habits. You know, roughly 30% of our methane production, our climate change changes are related to what we eat and how we produce food. I always remember this number is for if 1 gram of protein plant-based is what we should think about. It takes 9 grams to produce a pound of beef and 3 to 4 grams for a pound of for fish. So you're really something to think about. The other thing to think about is, you know, the amount of billions of animals that we're slaughtering on a regular basis. These numbers are astronomical. And you talk about the health benefits. So I think there's lots of reasons. Now, you don't have to become, you know, a vegan tomorrow, but you can do maybe 1 day a week or make a change here and there. And I started my journey with a bet on somebody, and so am I perfect? No. Am I better than I was before? Absolutely. So I encourage people to look at that. And the nutrition literature is full of lots of good information, some difficult to look at. And we learn that 2 common diseases, as you know, with having reflux, there's different ways of treating it, and things like colon cancer, how that can make an impact.
Great.
Dr.
Ganguli,
wonderful information.
Yeah, go ahead.
Is there any evidence that older people would benefit from getting on a plant-based diet? So the geriatric crowd, is there any literature on that?
Well, we know that all of the risk factors can be improved. And there are certainly anecdotal, like I've seen stuff posted all over the internet of people even in their 80s who find that they feel a lot better when they go on a plant-based diet. I don't think there are actually randomized studies of elderly people, but you know, losing weight, improving control of diabetes, improving blood pressure. Yeah. So basically there are multiple cases where we've seen it happen in individuals. So I have to admit, I don't personally, when I have patients in their 80s, I'm not really aggressive with them on diet. But yes, there are benefits irrespective of age. And it also probably extends to preventing Alzheimer's and dementia. So I would suggest it's never too late to start.
So I think, you know, this, you know, one of the things that we're seeing in every disease is that we're all aging, becoming more frail. So what you eat and how much you weigh have direct impacts. We talked a little bit of exercise and lifestyle, and the last 2 to 3 years of one's life is usually spent with bad illness for many of us. And what drives people to the nursing home is they no longer can walk, they fall, they can't think, and they need assistance to that. And so being as active, being as skinny as you can, and eating healthy foods is certainly a choice. We still have fantastic therapies and medicines, and what I'm seeing right now is that people want, as we get older, therapies that are too late. So think about how you prevent yourself from getting there. And any other questions from anybody? Daniel,
Just-
what's your thoughts?
I did have a question. I was curious because I think like looking at all the different dietary factors in terms of reducing colon cancer risk, the big one that stands out to me was the whole grains. And I know, Dr. Ganguli, you mentioned quinoa is the most accessible. I was curious, just for like our viewers and some of our patients as well, like what are some of the other, aside from quinoa, like are there any other common sort of whole grains or?
Yeah. Basically, the most common one is quinoa. Most people haven't heard of the other ones, but there's something called kamut, K-A-M-U-T. There's something called farro, F-A-R-R-O. There's something called hang on, kamut, farro. Teff. That's right, T-E-F-F. Those are the main ones. With whole wheat, yes, but it's incredibly difficult to actually get true whole wheat. And unfortunately, in the harvesting of wheat, they use a pesticide called glyphosate. And glyphosate, to be honest, is scary. So if you can get organic whole wheat, then that's okay as well. But it's the terms. This is one of the things that I follow that I explain to my patients in the small groups that I run to help them adopt a plant-based diet. Because basically, even enriched wheat, it isn't whole wheat. If it says cracked wheat or whole wheat, yeah, there you go. But yeah, for most normal people, quinoa is the way to go. And my wife occasionally trusts me to cook it, and she's incredibly firm. She says, do not stir it. So you put in the water, you put in the appropriate amount of quinoa, and you simmer it, and then you use a little knife or something to see when the water's gone. But she's very firm with me on that. She says, don't stir the quinoa. So if you're going to get into, if you're new to quinoa, just go on YouTube and see a video on it. But like I say, you figure out the water, you figure out the quinoa, and you just look, no lid, and you just gently let it simmer, and then you got to stick around. It takes 20 minutes. It's not real long, until there's basically the water's gone, and then it's light and it's fluffy.
One thing about quinoa, it's one of the vegetable products. It's a complete protein for those that are interested. And
fabulous point, Dr. Curnew. Soy and quinoa are two of the most perfectly balanced plant proteins. It's a great point. And just to follow up Dr. Curnew's point on exercise, you can decrease your overall mortality by 40% if you get enough exercise. And there's something kind of new in elderly people called frailty, because Dr. Curnew mentioned people falling and breaking their hips. There's something that goes with frailty called sarcopenia. It means loss of skeletal muscle. And this basically starts happening when we're 50. And this is why, like literally this morning, I had a Zoom at 7:30 till 8:30. I had a Zoom at 9. I lifted weights from 8:30 till 9, because that's how we prevent the loss of skeletal muscle. It's a big deal.
Dr.
And,
Ganguli, we actually have a question in the chat as well on our YouTube stream. We have one of our patients is wondering about oat and almond milk in terms of, I think, probably, GERD as well as, colon cancer risk.
Sure. So plant-based milks don't have the risks of animal-based milks. Point one. Point two. There's a continuum of how kind of zealous you want to be. To put it simply, there's nothing wrong with almond milk. It is good for you, but it goes through unbelievable amounts of water to grow the almonds. Oat milk environmentally is probably your best bang for the buck. And there's a brand of oat milk that we get called Earth's Own Naked, N-A-K-E-D oat milk. And the reason that we get that one is it doesn't have emulsifiers and stuff in it. So you can get it at Farm Boy and stuff. So basically oat milk is the best way to go. And if you just give me a second, I'll pop up a picture of exactly the milk that we get. You can get it at Goodness Me, you can get it at Farm Boy. And that's kind of the best one. Here we go. Here, if you don't mind, I'll just screen share. Woohoo. Doing. Okay, so yeah, you see this. Let's see. I'll maybe even see if I can make it pop up. Oh, watch out. Yeah, here we go. So you see how it has that funny thing that looks like a clover leaf on it. So it says Earth's Own Naked 4 simple ingredients. That is basically the best milk you can get because it's oat based and stuff. Like I say, there's nothing wrong with almond milk, but it's just it literally the amount of water to grow them is huge. But so any plant-based milk is good, but that's the brand that we get at Goodness Me and at Farm Boy because it only has 4 ingredients, because these emulsifiers basically give us leaky gut, and who knows, it's possible it may be related to Crohn's and ulcerative colitis. Anyway, processed food's not our friend either. These are all things.
One of the things. Question about quinoa. There's different color quinoa. What does the color tell you?
All the quinoa is good, but almost without exception, the darker or brighter a color is of a fruit or a grain, the better. So if I had the choice, I would get either black quinoa or red quinoa, but it's not a big deal. I mean, the regular colored quinoa is just fine. I'm only aware of 2, quote, white foods that are really, really good for you. One is oats and the other is cauliflower. I'm sure there might be exceptions to that. But as a general rule, the brighter the vegetables, you want to eat the rainbow. But in general, like, for example, black rice has all of these lovely phytonutrients that white rice doesn't have. And so it goes on and on and on. But like I say, all quinoa is good, but if you can get either red or black or multicolored, it's even better.
So other white foods that you might consider, you can have onions, cauliflower, join that list as well. So
yes, onions are good. Onions are good, but funnily enough, red onions are a margin better, but it's all good. They're all good.
Where does potatoes fit into your scheme of things?
Yeah, there's nothing wrong with potatoes. Just as long as you don't have them in excess. I mean, yeah, there's nothing wrong with them. But once again, sweet potatoes, which are orange, have this carotene and these other phytonutrients. That's even better. But in moderation, there's nothing wrong with potatoes at all, really. Yeah, and culturally, some people really, really like their potatoes, but try and have them with the skin on. Well, almost without exception, the outer millimeter of the apples or the potatoes, that's where a lot of the best stuff is. So sure, yeah.
Well, this is truly wonderful. And any other points from anybody at all? Because I think what I take away is that we undervalue Mother Nature. And I heard some numbers. I'm not sure if it's $800 billion around the world is spent on supplements and vitamins and things of that nature. And most of it is useless. So eat real food. Mother Nature has a secret cocktail, secret sauce, secret recipe, and we as human beings muck up on this. And so I like this idea about whole real food as being our medicine as well as our nutrition. So
I see a question in the chat box about organic fruit and vegetables. If you go to my website, I've got a whole page on that. Basically, by going organic, you decrease the dose of pesticides, and pesticides are not our friends. So and then there's something called the Clean 15 and the Dirty Dozen. So if you go to and once again, if you just go to my website, on the main menu, it says organic fruits and veggies. And I talk about the clean, the Dirty Dozen are the high pesticide fruits and vegetables. The Clean 15s are the low pesticide fruits and vegetables. That's it. Anyway, sorry, Greg, I interrupted you, but I just saw the question.
No, that's perfect.
And I had a feeling that we were ending, but yeah.
No. Any other questions, anybody? Well, with that, as I just want to thank everybody. This is one that people should go back and look. That's why I like these recordings, because I go back and look. I realize that I hear somewhere between 7 to 20% of information that's presented is remembered long term. I think I'm closer to 3% sometimes. So I have to go back and review in multiple formats. So I'm going to encourage people to come take a look at this. And I want to thank Priscilla, Dr. Ganguli, of course, Daniel, and the rest of the team for always keeping us on track. And I got to go and do a little exercise, and I'm going to go play some hockey. I'm playing on a hockey team. We're in the finals. No thanks to me. I'm good for the other team. So I want to give everybody a great night and lots to think about. So thank you so much, everybody.
Well, thanks, Dr. Curnew, for having a medical team that cares about their patients' health more than any doctor I've met in Hamilton. Thanks to you folks for hosting talks like this. All the best. Bye.
Take care.